This is a presentation about tricuspid valve disease. So our patient is an 88-year-old gentleman who had surgical aortic valve replacement in 2005 for aortic stenosis using a tissue biprosthetic valve, Anchor 2. However, this one degenerated and he required a TAVI in 2017 with a valve-in-valve, Evolus R cold valve. He now presented to the ER with increasing edema despite escalating diuretic doses. Physical examination showed blood pressure of 85 over 60 millimeters of mercury, heart rate of 60 beats per minute irregular. On auscultation, he had pancreatic murmur loudest at the left lower sternal edge, with edema up to anterior abdominal wall, and abdominal examination showed tender hepatomegaly. He was on torsemide 40 milligrams per day, Flurinone 50 milligrams per day, bisoprolol 5 milligrams per day, digoxin 0.125 milligram every other day because of renal impairment, and warfarin 3 milligrams per day for atrial fibrillation. The ECG showed atrial fibrillation with controlled ventricular response. Echocardiography showed ejection fraction of 60%, well-functioning aortic valve prosthesis with gradient of 24 millimeters of mercury and mean gradient of 15 millimeters of mercury. However, he had severe tricuspid regurgitation with a vena contracta of 13 millimeters and effective regurgitant orifice area of 0.9 centimeters square. He had an estimated pulmonary artery systolic pressure of 40 millimeters of mercury. His right atrium and right ventricle were dilated with impaired RV systolic function with a fractional air change of 32%. His lab shows a creatinine of 1.8 milligram per deciliter, potassium with a normal limit of 3.9 milligram per liter. Anti-BroPMP was markedly elevated, and gamma GT was also markedly elevated. His INR was within therapeutic range of 2.1. He had a coronary angiography prior to his TAVI procedure, which showed normal coronaries, and he had right heart cath as well, which showed a systolic pulmonary artery pressure of 50 millimeters of mercury and pulmonary capillary wedge pressure of 13 millimeters of mercury. This is from his transesophageal echo, which showed this is the tricuspid valve, the septal, anterior, and posterior leaflets, and he had severe tricuspid regurgitation, so these movies are not playing. So what's the problem? This is from a cadaveric specimen of the human tricuspid valve, showing the septal, anterior, and posterior leaflets. And in majority of patients with tricuspid regurgitation, it is secondary or functional tricuspid regurgitation. Please note the location of the AV node location to the valve, which is of significance when considering percutaneous options for therapy or tricuspid regurgitation. So this functional tricuspid regurgitation is mainly due to annular dilatation, with this lateral annulus progressively dilating. And this is from a publication on functional tricuspid regurgitation, which initially starts with annular dilatation, and this tricuspid regurgitation, annular dilatation, begets further RV dilatation and lack of leaflet coaptation, and finally we end up with a dilated RV with tethered tricuspid valve leaflets. So this is from the ESC 2017 guidelines, and the management of tricuspid regurgitation is an area of less evidence than left-sided heart valves, and it crucially depends on the need for left-sided valve surgery. So in this patient, we don't need left-side surgery, and we have a severe secondary tricuspid regurgitation. So the question here comes to the presence of severe RV or LV dysfunction and severe pulmonary hypertension. In this case, we have an RV dysfunction, but it's not severe, so fraction air change below 35% will be abnormal, and he has a fraction air change of 32%. So he has RV dysfunction, but it's not severe. And in this case, he is markedly symptomatic. He cannot tolerate further diuretics. His blood pressure is 85 over 60 millimeters of mercury, and he's been up to anterior abdominal wall. And his symptoms, so he would require tricuspid valve repair, or replacement repair is not feasible. And these are the indications in the guidelines, where we have a secondary tricuspid regurgitation, and we have severe secondary tricuspid regurgitation. He's not undergoing left heart surgery, but he has progressive symptoms refractory to medical treatment. So the techniques for tricuspid valve repair, there is the suture repair of the annulus, which is the Vega repair. We have a surgical annuloplasty, or we have edge-to-edge repair. So the percutaneous options for tricuspid valve repair try to replicate these techniques, with these most widely used being an edge-to-edge repair with a mitral clip device. Other devices are currently in development, like the annuloplasty devices, the millipede or cardioband. The problem with this patient is that he has already undergone a TAVI in 2017 because of a heart team discussion and this is based on his Euro 2 score, which deemed him to be very high risk for surgery. This is the Euro score calculator. It's based on the age, gender, presence of chronic pulmonary disease, extracardiac arteriopathy, neurologic dysfunction, having undergone previous surgery, serum creatinine, and other factors like active endocarditis, treatment preoperative state, unstable angina, recent myocardial infarction, the pulmonary artery pressure, the ejection fraction, as well as the weight of the procedure, how many procedures, and whether it's CABG or other non-CABG surgery. So this patient's Euro 2 score estimates the risk of in-hospital mortality of about 10%, which is high risk. And bear in mind, this does not factor the RV dysfunction, which would increase his operative risk further. So this patient was offered the option for percutaneous tricuspid valve regurgitation. These are other options for regurgitation. The simplest would be the edge-to-edge microclip. Others would be coaptation devices or valves implanted in the superior and inferior vena cava, as well as annuloplasty devices. This is the percutaneous annuloplasty device. This is Coliban and the millipede. So the millipede is attached to the annulus, and then this is cinched and it narrows the annulus. He had a mitral clip implanted in tricuspid position. We already saw the sternotomy wires, and here this is the ring of the original tissue, the failing valve, and I hope you can appreciate the nitinol frame of the Evolus R valve, which had been implanted 1 year before. This is REO projection, and then the valve is released. The procedure is, of course, under TOE guidance. Following the procedure, he had improvement of tricuspid regurgitation from severe to moderate. This translated into functional improvement with improved edema and increased functional capacity, decreased fatigue. So the largest data set for the use of mitral clip in tricuspid position is from the International Tri-Valve Registry, which was presented last July in TCT. It includes 313 patients from several countries, and by and large, it showed a reduction in tricuspid regurgitation from baseline to 30 days after the procedure, which was highly statistically significant. However, the RV function did not change, but translated into clinical improvement in form of symptom improvement with knee class improvement, as well as reduction in ascites and peripheral edema. The overall survival for these patients after the procedure was quite good, with 77% surviving at 1.5 years. Interestingly, the survival was increased with patients who had procedural success rather than procedural failure, as well as in patients who did not have severe pulmonary arterial hypertension. So this gives further support to the percutaneous tricuspid valve repair solutions for patients with increased operative mortality. And of course, these patients with RV dysfunction have a very high operative mortality. However, there's of course room for further improvement. Thank you.